Us tonight. My name's Katie Pryor, and on behalf of the Western New South Wales PHN, I welcome you and thank you for taking time out of your busy schedule. I'd just like to start with an acknowledgement of country. I'd like to acknowledge the people of the Wiradjuri Nation as I'm sitting here in Bathurst and the different nations on which each of us sit this evening. I pay my respects to elders past, present and emerging, and acknowledge their continuing connection to land, water, culture and community. And I extend that respect and warmly welcome all Aboriginal and Torres Strait Islander Australians who are here with us tonight. Thank you for joining us. Just a little bit of housekeeping. We're running this as a Teams meeting because we encourage your questions and interactivity, but we just ask if you're not speaking, if you could please just mute yourself so that there's no interruptions to the sound quality. If you do have a question or a comment, if you can let us know by virtually raising your hand on your toolbar, and we can then ask you to unmute and ask your question. If you don't want to talk, we can also take questions from the chat box and manage them from there. So please do make your comments, ask us your questions when we get to the Q&A session. And we are recording this session. We realise it was late notice and some people may not have been able to make it, so we can send the recording to those people. We warmly welcome all our presenters and panellists this evening, especially Dr. Ivy Chua, who is a GP from Dubbo. He's also on our Western Clinical Advisory Council, the Rural Co-Chair of New South Wales Health's COVID-19 Primary Care Community of Practice, Clinical Editor for Western New South Wales COVID-19 Health Pathways, the RACGP representative on the THANZ Multidisciplinary TTS Guidelines Committee, and involved in the provision of shared care for COVID-19 patients in recent outbreaks in Dubbo. Ivy has a lot of insights to bring us this evening. Also welcome to Lisa Gibson, who is a pharmacist from Dubbo and similarly has lots of insights from the recent outbreak in Dubbo to share about how pharmacy can manage through these outbreaks and with our patients in the community. And we also warmly welcome Andrew Coe, who's the CEO of Western New South Wales PHN. Thank you all for your time this evening. Just a bit of a overview of what we'll be talking about tonight. We'll have an update from the PHN from Ivy and Andrew on the role of primary care in Western New South Wales for COVID positive patients and living with COVID. We'll then move to Lisa, who will share with us her insights, and then we'll open up the floor for all your questions and comments to our panel. So I will now pass over to Ivy and Andrew to bring us an update on the situation currently.
Thank you, Katie. Just like to start by saying actually the main part of this talk is Lisa's insights, because that's tremendously important in how we're going to move forward in terms of caring or shared care of our patients in this next phase of living with COVID. I'll just share with you a few slides that can give you a bit of a background to where we're heading in New South Wales overall, and specifically in Western New South Wales. Here we go, slideshow. Are my slides showing up on screen at the moment?
They are, yep.
Lovely, thanks for that. Okay, so just a quick Cook's tour through what I'll talk about is we'll have a little discussion around what living with COVID might look like in terms of numbers, give you some background as to level of risk and the risk stratification that's being done for patients with COVID at the moment, and will certainly continue into the next phase of living with COVID, what it looks like to care for a COVID positive patient at home, supports available for GP teams so that you've got some idea of where that's heading, and some questions and answers, but feel free to ask questions along the way as well. This is going to look rather small, but the idea is, this is what New South Wales Health presents to us participants in the clinical council each and every week. This was actually the one from the 24th of November when they presented to us the data from the previous week. But if you squint your eyes, you can see that New South Wales at that point in time had a vaccination rate of 76%. So that's the 76% of the whole population, not just the 16 plus population, but the whole population. And you can see that the average cases per million then was reasonably good, 24 cases per million. But looking at all these other countries listed on that table below, they're all at different levels of loosening of restrictions. But you can see these other countries that have got fairly similar vaccination rates to us. It varies anywhere from, where we're sitting in New South Wales at the moment in terms of case rates to really quite some frighteningly high figures that Belgium was seeing at that point in time. So meaning to say, anything can happen in that next little while once all our restrictions are taken off, and we transition to living with COVID rather than where we've been at in terms of, COVID zero was the aim previously. The good news is, we do have a highly vaccinated population, and particularly in Western New South Wales, I think the combined efforts of pharmacy, general practice, New South Wales Health, visiting teams, combined efforts has meant that we've got incredibly high vaccination rates in our patch. And, that stands us in good stead because despite COVID being a prevalent disease in the near future, most of the people with COVID will in fact have a very, very good prognosis. And we're talking 85%, straight away will do well with very minimal symptoms, if any. There will still be that proportion who get very, very sick, have serious disease, need hospital admission, intensive care, and there'll be a level of mortality associated with that as well. And we do have those pockets of people who still refuse to get vaccinated, unfortunately, and the risk of severe disease is quite high. So for the patients who do end up developing COVID, I mean, if we look to see when do they fall sick, if they have a clinical deterioration, it's most likely to occur between days 4 and 10. And that's a reason why we're monitoring them closely during the acute COVID illness. And you'd be aware that a proportion of people do also go on to develop long COVID, and that's more likely if they're unvaccinated. It's more likely if they've been in hospital very sick with their COVID. And the risk of clinical deterioration, I mean, we do have some predictive factors now. When COVID first started, we had no idea what put somebody at risk versus not at risk. It was all a bit of a guess. But now it's very, very clear. There are these 5 things that help us decide whether someone's at high risk or medium risk or low risk of clinical deterioration. And those 5 things are the age. So people who are younger do better. So pretty much when you're 12 months old to the 50-year-old age range, most of them will do really, really well. And you might have already come across those people who have had COVID in Dubbo or other towns where, they've had no symptoms or they've had very mild symptoms indeed, and particularly more so if been vaccinated, because that's the next obvious risk factor. So unvaccinated versus vaccinated. Medical risk factors, so obviously somebody who's got diabetes, heart disease, pulmonary disease, immunosuppressed due to medications or due to the conditions that they have, cancer, living with cancer, but also people who are pregnant and also people who are obese. Those are some of the medical risk factors that we are very clearly associated with a higher risk of deterioration. Social risk factors are there as well, and you'd know that your patients who are less health literate, lower socioeconomic background, who don't have easy access to phone and internet, and who don't have easy access to the GP. Those are some of the social risk factors we get concerned about, and that does put them into a higher category of risk. And in fact, most of the patients in Western New South Wales who have developed COVID to date have rated high on the social risk factor category. And the presence of COVID symptoms also obviously makes a difference. So somebody who's already having breathing difficulties, desaturating, who's got evidence of COVID myocarditis or COVID colitis. So if they've already got symptoms, that puts them into a higher risk category, and they're better off looked after, not in primary care, but by hospital-led teams. So I won't go into this into too greater detail, but suffice to say, looking at those 5 risk factors, we can class people into low risk with the COVID infection all up versus medium risk and versus high risk. And people who are in the high risk category, who are so little bubbies, those who are an older population, who are unvaccinated, that's a typo, I should have fixed that, medical or social risk factors, and have got moderate or severe clinical symptoms with their COVID, those people are higher risk, and they just need to be looked after outside of primary care. They need to be looked after by a hospital-led team. So in terms of caring for COVID positive patients at home, where we were before in terms of COVID zero, the aim to be that we suppress and eliminate COVID, which when is no longer achievable. But in that phase, that was hospital-led teams providing care for all COVID positive patients. So that's where we've been to date in Western New South Wales. We've had the hospital-led team, largely based at Orange Hospital. We've also had in the Far West location, we've had the hospital-led team there providing all the care for COVID-positive patients. Now we're in this sort of grey zone of the transition phase, because at any minute now we're expecting that we're going to get a rise in COVID case numbers, and it's predicted that probably January is the time when we'll see that surge just beginning. And probably peaking around April or so. But during that living with COVID phase, the model of care that's being suggested at a national level is that there'll be risk stratification provided by an organisation called Health Direct. That's a government organisation, and from there, that the people who are higher risk will be put into the care of hospital-led teams, but that the people who are low to medium risk will be put into the care of GP teams. And across our region, we'll look to see how that turns out. For some of these patients, it will be the usual GP team who provides that care. For other patients, it might be that that particular GP team isn't in a position to look after that patient, but in fact, another GP team within Western New South Wales might provide that care. And failing that, we may well need to pull in other commission services to provide that care to those low, medium risk patients. So there's been a lot of work going on behind the scenes to pull together supports for primary care. And one really important resource that it'd be worthwhile for all of you to jump into and familiarise yourself with is Health Pathways. And if you haven't already looked at that, basically it's guidelines that are mainly targeted at GPs, but for community nurses, practice nurses, pharmacists, general sort of primary care team players, it's worthwhile having a bit of a squiz at that and getting yourself familiar with what COVID care looks like for low and medium risk patients. The PHN will be put in charge of having oximeters distributed to patients, and one of the ways we might need to do this in the more remote communities is actually to pull on the help of pharmacy, and I'll let Andrew talk more about that in a minute. There have been patient instructions around COVID conditions, but also about how to use oximeters and self-monitor during the COVID illness. There's a piece of software called Inca, which will be a godsend in terms of shared care. And in fact, pharmacy involvement in that would be really good as well. The Western New South Wales and Far West local health district teams have got the supports available. So anybody in primary care would be able to ring them up for local advice if we're concerned about a COVID positive patient. And certainly for pharmacy, working closely together with your GPs to obtain advice and share ideas about patient care would be really important as well. And the PHN are working around providing commissioning of services that will support all of this to go ahead. Bearing in mind that we do have limited primary care workforce across the whole of our region, so potential needing to commission services from elsewhere as well to support what needs to go ahead in the next little phase. So that was a pretty quick run through, but any questions at the moment before I hand over to Lisa? And actually, Andrew, if you wanted to talk through about the oximeters further. On mute.
Well, there you go, that's better. Yeah, thanks, Ivy. Look, a couple of things really. One is the PHN is here to provide support to any healthcare provider within the catchment. I mean, as Ivy said, this is a team effort. So we're going to be supporting general practice, but also pharmacy as part of the solution for those patients. I think we are focusing on multidiscipline team approach with these individuals. So I think pharmacy will have a big role to play. But with regard to the equipment, these oximeters are going to be distributed by the PHN. So we're bringing them from a national stockpile and then distributing them to patients. The idea is it will be delivered to patients' home through a sort of strict infection control arrangement. Some of that we hope we'll be able to use already systems and processes in place. So with regard to pharmacy, where you've already got a medicine delivery type arrangement, we would hope to be able to link into that so that we can provide the same sort of service to patients. Often it will require the delivery of both equipment and perhaps some medication. So we hope to be able to link in with the services that some of you already got in place, and we're trying to map those services across our catchment. For those areas where we don't have, perhaps a pharmacy service, we are looking at a courier service, and in some cases, particularly in the far west, we are looking at other partners, so particularly the ambulance service being able to deliver some of these packages to patients. But all that is sort of currently under development across the system. I think the other thing that Ivy touched upon is the Inca software, and we hope that that will enable us to be able to share patient information in real time across the care team, and I think that will be really important as we see more and more people being managed in primary care. And part of that process, of course, is to move people who become acutely unwell into the hospital system. I think that's probably it, Ivy, unless people have got some questions.
All good. We might hand over to you then, Lisa. Lisa was very much involved in the care of COVID positive patients in Dubbo with the recent outbreak, and Lisa and her team were called on many a time to deliver packages to the COVID positive patients who were looked after by the hospital team, and has plenty of insights to share with the group, and I'm sure would be happy to take questions as well as we move through her presentation. Thanks, Lisa.
Thanks, Ivy. Can you see my screen and hear me fine?
Perfect.
Okay, great. So as Ivy said, my name's Lisa. I'm a pharmacist based in Dubbo, and currently our team's been working with LHD in delivering medication to patients as part of COVID care in the community program. And I've just been asked to discuss some of our experience and also some points to consider in rolling this out to the wider area. So most pharmacists will be very well versed in what I'll run through, but I thought I'd just highlight a couple of points just around prescriptions, stock management and delivery. So the first area I'll talk about is prescriptions. So as you all know, we can utilise the image-based prescription legislation for the majority of medications. That legislation is up until the 31st of December. And I haven't heard whether or not we have an extension past that date, but with that potential end date in mind, it's important to continue to promote the benefits of electronic prescriptions to those practices not on board yet. So I would start that now. If you've got any local surgeries not utilising electronic prescriptions, definitely perhaps get the PHN team involved to assist in that. It's worth noting that we do see a reasonable number of S4D prescriptions prescribed to this cohort of patients, mainly diazepam. There's a considerable amount of anxiety amongst patients, and we have seen quite a lot of urgent requests for delivery of medication. We've experienced a few issues with this process, particularly around authority scripts, missing patient data such as Medicare and concession cards, but hopefully this situation will be reduced with our low to medium risk patients, hopefully being managed by their regular GP, and the prescribing software should have all of that up-to-date information. The main thing on the patient data is one very important detail to confirm is the actual delivery address, as the patients may not be staying at the usual home address, which their GP has recorded in their software if they're isolating from other family members. On to stock management. The majority of medications prescribed are common, and you would have plenty of stock within the dispensary, but you can review in more detail some of the more common medications via that Health Pathways website, which Ivy shared before. And we do see a lot of requests for over-the-counter items to be delivered as well, just regular items that the patients can't access. And the final area to cover in delivery is the biggest factor. We need to consider how we're going to communicate between the surgeries and the pharmacy that the patient is COVID positive and requires delivery of the medication on that same day, particularly if the script requests are coming through as an electronic script. So I think that's something which Ivy might touch on later after I finish this presentation. So with delivery in community pharmacy, it's become commonplace for us all during the pandemic. We all have our COVID safe delivery processes in place, but the main focus for our delivery drivers is to ensure that they're not confusing COVID safe deliveries with deliveries to the COVID positive patients, because these may be quite different depending on your processes. Currently, with our COVID patients in the community, we're placing the item at their front door and then phoning the patient from the delivery car to confirm their collection and discuss any questions or any counselling needs that they've got. Two factors you just need to consider in this process is, are we meeting our legislative requirements for the delivery of Schedule 3 and 4 medication, and how you might manage deliveries which require demonstration of new devices such as a Rapihaler, Turbuhaler or Spacer, or any devices which they're prescribed. So sometimes we do see their regular medication requests being sent through, so there might be some different devices as well you need to cover off. And then my final point is, don't forget to claim for the delivery. We're still able to be paid for the delivery to those patients. And the funding for that is due to expire at the end of December with an extension to be confirmed. And that's all I've got to cover off. I no doubt believe this will keep us all very, very busy through next year to that peak that Ivy talked about in April. And then that'll roll us into our influenza vaccination season. So we'll be very, very busy. Did anybody have any questions at all? No. I'll hand back to Ivy or Katie.
Oh,
Thank
sorry.
you, Lisa.
Sorry, Lisa. It's Christy from the PHN. I was just going to ask, I'll just put my camera on. I was just going to ask about when you do deliveries out in rural, remote areas around Dubbo, what sort of, who do you use in those places to be able to help you guys? Do you use the post, or do you use local pharmacy staff or health services that are already there?
Yeah, so currently we've been looking after all deliveries to all areas sort of within our catchment. So Narromine, Gilgandra, Wellington, sort of the smaller local communities in between. And then the LHD team has had pharmacies in the other areas who may be closer, but we're sort of doing within that sort of nearly 100-kilometre radius.
Thank you.
Thanks for that, Lisa. And you'd mentioned about maintaining stock of medications, and I guess at the moment, in terms of symptomatic management, because that's largely what it is for somebody who's sort of lower risk COVID. If they do become symptomatic, you know, what do we expect? Might be a runny nose, might be a sore throat, might be a fever, mild fever that comes and goes, maybe headaches, perhaps a dry, irritating cough. And so the most common medications, you know, will be the same medications that we might use with somebody with a viral upper respiratory tract illness for the main part. However, the only sort of special medications that we think about from the COVID perspective would be more recent guidelines that have come up saying that somebody who's COVID positive, just developing some mild respiratory symptoms, it's worthwhile considering budesonide, 800 micrograms BD for up to 14 days. And so that's something potentially that you might see being prescribed more in the next little while compared to what we have done in the past. The other things that's worthwhile knowing about is that very strict guidelines around stopping nebs and changing people to meter dose inhalers and spacers. So if you are aware that you've got a patient who's on nebs, and if the GP maybe has forgotten to switch them over to an MDI and spacer, then that would be a good thing to sort of work together to get underway. So perhaps you may need a little stash of spacers sitting there as a just in case. So, you know, the patients who already have existing asthma and COPD, they're very likely to be converted if they're on nebs to MDI and spacer. But otherwise, yeah, you know, paracetamol, ibuprofen, antihistamines. COVID dermatitis seems to be not uncommon, so emollients and topical steroids may well be asked for. Bit of COVID conjunctivitis seems to appear every now and then, so might just be a matter of saline drops. Occasional antibiotic drops may be prescribed. And pretty much that's about it. Anything that requires more significant therapy than that, realistically, that patient will be under the care of the hospital-led team. So yeah, what else did we use? Look, we used dexamethasone in the aged care facility situation, but yeah, for the most part, I mean, that ought to be handled in the hospital setting as an admitted patient who's needing oxygen therapy. So it should be fairly basic from the point of view of symptomatic support for our mild and medium COVID positive patients. In terms of being notified when a patient is COVID positive, I really hope, because I made it really clear in Health Pathways, I think, that your GPs who are providing care for COVID positive patients, that they will, at the time of issuing a script, also notify the pharmacy that they're working with to to flag that this is a delivery required. It's in a COVID safe delivery required, as opposed to that the patient's going to come in, or that you're going to knock on the door and have a good chat with them at the door whilst handing over the medications. And if there are any issues with that at all, you know, it'd be worthwhile feeding back to the PHN, who can just maybe just do a little bit of extra top-up education as required for particular practices. Questions?
Yeah, I was going to say, anyone, pop your questions in the chat box or raise your hand, or any comments as well. We've definitely got time to cover everything off.
Just out of curiosity, also, we've got a whole bunch of pharmacists on the group. E-scripts, are they going okay? Are they easy enough to do? Patients bringing along the e-scripts to you?
I think, Ivy, from my experience, we were having a chat today about it. A lot of patients are having trouble not having a piece of paper to take home with their repeats. So there's 4 options when we can issue the repeats. We can issue a paper copy. We can send the repeat token via SMS. We can send it via email, or we can create an active script list. By far the easiest one for pharmacy to work with is the active script list. This is from my personal experience. Patients trying to find the repeat token issued by an SMS, they sit there and they flick through and scroll, or they try and find it in an email. So it's just, I guess, that patient education, that it's ideally moving to it all being electronic. But in terms of, you know, we don't have to chase faxes. The original copies of faxes, the doctors don't have to worry about, you know, writing on the Schedule 8s. There's so many benefits, but just retraining patients and getting them to accept that it's all electronic now, if they'd like it.
It is like that in my experience. I've got a whole cohort of patients who've gone, oh, this is fantastic. I just can search for it in my email. And then others have gone, oh, you know how last time you gave me that e-script because we were in lockdown? Well, could you just print me out a bit of paper this time?
Yeah.
So, Lisa, the logistics of making it a COVID safe delivery, what were the steps for the most part? Was that kind of a drop into the letterbox and run? Was it a then phone them and talk to them about the medications? What did your team tend to do?
So we'd receive the correspondence from the hospital team. Generally have quite clear instructions around delivery locations. So some of those patients were in the SHA accommodation. So there would be a contact, whether it be the nurse or security. But those patients living at home, we would drop the parcel on the front porch and then give them a call from the delivery car saying we've dropped it off, any questions, any important counselling information that we had to pass on. And if there was something sort of more specific, as you mentioned, there's quite a lot of use of spacers in these patients. So if they'd never used a spacer before, then we'd run through a few different options, whether it was sharing a video on how to use a spacer, and whether that be via email or SMS. So that would sort of, it depended on how much experience they'd had with the device or the medication. Also, there was quite a lot of patients with low health literacy. So sometimes we had a more detailed discussion or conversation with them. So it really depended on the patient's needs. But usually they'd be sort of looking through the window, waiting for us to come because they knew we were coming anyway. Yeah, so most patients, it was dropped to the doorstep and back to the car for the conversation. So, yeah.
And there's been a fair bit of concern, I think, in general in primary care land about PPE and risk for staff and contact with patients. Did you find on any of those occasions that you did have to do a face-to-face contact with PPE on?
No, we didn't. We worked with the hospital team. There was some patients which were very challenging because of literacy, but we worked around that just on an individual basis, depending on their needs. But you know, most people have got phones and can watch videos as long as they've got data. And credit on their phone, that was okay. We didn't come across anybody who wasn't able to access the video, sending them through. But that's perhaps one thing to consider if they haven't got data, which is a challenge with e-scripts that we've found. They can't open up the SMS if there's no credit on their phone.
Yeah.
Yeah.
And for other pharmacists who are online, I'd be curious to hear your experience of COVID care to date as well. Would anyone like to speak up about that?
It's a quiet group tonight, Ivy.
Ivy, my name's Lauren. I'm from Western New South Wales Health. You've mentioned a couple of things that the pharmacies work with the hospital team to address, like the health literacy. How are we going to do that if this is kind of GP without the hospital team involved, or would those patients be transferred to the hospital team?
Yeah, so I mean, going back to the risk stratification, the demographic that has been hit hardest to date are those who have had struggles, often in the social risk factor situation in addition to medical risk factor situation. So, look, if somebody's in that risk profile where they are struggling with their health literacy and they're needing that multidisciplinary team wraparound, realistically that person is going to be a high risk patient who falls into the best looked after by the hospital-led team rather than by the GP team.
Okay, thank you.
It's Christy again. Oh, sorry, Andrew.
Yeah, look, I was just going to add to that. I mean, I think we're on a steep learning curve, and I think Ivy's right that in the short term, we would probably look for those that are struggling to be dealt with by the hospital system. But as Ivy said early on, I mean, I think we are going to see large numbers of patients coming through the system early next year. And what we'll see over time is as general practitioners pick up these patients and manage them, they'll be learning through the process. And I think what Lisa said is exactly right, that some of the pharmacies will get experience and learn from the process, and we'll be able to give enhanced services to those that need the extra social support. And where there's those health literacy issues, we are going to try and keep the patient information up to date and relevant. And if we think there's some more information we should be giving to people, that we will adapt those information sheets as we go.
I was just going to. Oh, sorry. I was just going to ask Lisa. Do you work well with the GPs at the moment, handing over care or vice versa?
Yeah, I think during the pandemic, definitely electronic scripts have made our communication much easier. and all the, the GPs and the teams, I think that in pharmacy and general practice have worked extremely hard trying to meet the needs of our patients. So I think, we definitely there'll be bottlenecks in the process, but it's not something that we can't work through. And I think the PHN, if there's any areas which pharmacy or GPs need assistance with, or we need to streamline some processes, I'm sure there's assistance available for that.
Hello?
Yes, who's there?
Oh, yeah, so I'm Anne. I'm from Dunedoo out in the Central West and not far from you over there in Dubbo. And we've had no COVID positivities out here, just within 10 Ks anyway. I just thought I'd make a comment about the QR codes or electronic prescriptions. There is a way to make those repeats more accessible to people, and the pharmacist could issue the tokens to the phone of the person that's actually had it originally, or the patient that's had it originally dispensed, so they could find it in that sea of emails, as you spoke, or well, usually it's in the message section, a little bit more easily. Also, yes, you can print out that QR code to allow a repeat prescription to be done within the pharmacy, but it's a little bit more awkward, of course, if it hasn't been initially dispensed. Yes, so I don't know if that would help, but I have to congratulate the PHN and how everything was orchestrated with medication delivery for the COVID positive patients in the district. It's astounding. Well done.
Thanks, Anne. Has anyone else got any questions or comments they'd like to add?
Hi, it's Andrew again. Lauren, was there something else you wanted to add?
Oh, I was just going to say that one of the things that we did with the community care team was provide symptomatic packs, which included the simple analgesics that you mentioned earlier, Ivy, the paracetamol, ibuprofen, and we had hydrolite in the packs, or have hydrolite in the packs. So they go to every patient that is COVID positive. And we have ones for adults and for children. The other thing that we found was reasonably significant was nicotine withdrawal. So we made up some NRT packs as well. So that just might be something you need to consider when this transfers to primary care.
Really good point. Yes, thanks for that, Lauren.
Yeah,
Must
thanks.
add
Lauren.
that to the armamentarium. And certainly, yes, I'm aware that the CCIC team at Western New South Wales, they'll actually had to deal a lot with drug and alcohol withdrawal situations. And I think, Lisa, that was probably the bulk of the diazepam that was being prescribed, was in terms of managing withdrawal situations there. But yes, the smokes as well. They wouldn't have the easy access that they normally do.
Methadone was a challenge as well, sorry, Lisa.
Oh, sorry, Lauren, you go.
I was just saying methadone was a bit of a challenge too, how we delivered that.
And look, I think with that too, and I guess, from a GP perspective, we might have it a little bit easier in terms of, we'll be looking after the low to medium risk patients. Hospital will be looking after the high risk patients, but lucky pharmacists get to look after the whole breadth, in the sense that you'll be tapped on the shoulder to support GPs with the low to medium risk, but you'll also be tapped on the shoulder to support the hospital teams with the higher risk patients. And certainly, yeah, that might include then those other medications there that may need to be utilised for those with drug and alcohol withdrawal needs, perhaps more complex mental health situations, and be more symptomatic with the COVID disease as well. one other thing I'd just like to is that in terms of aged care facility management, and that will probably be something else we've got to think about in greater detail down the track too. For us in Dubbo with our 2 aged care facilities who are involved, unfortunately, those particular facilities didn't have electronic medication charts in use. And oh my goodness, that was challenging. I'm sure from the pharmacy end, it was just frustrating. We GPs found that extremely frustrating in the sense that the way we ended up trying to get around this lack of electronic med charts would typically be the COVID nurse, so the nurse in the red zone of the aged care facilities would end up taking photos or screenshots or scanning the patient's medication charts, and had come to us GPs and would scribble on it and try to forward that to the pharmacy. And for some pharmacies, we managed to do that via email. For fax was too hard to do for most GPs because we were effectively mostly doing it from home during the lockdown period. So yes, email was often how we got it across. So it was very handy to have email addresses of the pharmacies to correspond with when it came to those aged care facility med charts. And then similarly with scripts, not being able to do an e-script for the aged care facility resident like we would for other people who were sending the e-scripts directly to them, meant that often we would print out a script and then we'd scan that and email that through or fax it through to our pharmacies. Do you think, Lisa, there might have been any other way to do that better with the aged care facility outbreaks?
Yeah, it's extremely challenging without an electronic chart and electronic scripts. I think what we've moved towards doing is trying to get our facilities all on electronic charts. I saw, did I see somebody from one of the pharmacies on? Let me just have a little look. I thought. No, there's not. There's not really any sort of workaround that I can think up at this point, Ivy.
Claire, you've got your hand up.
Oh, thanks, Ivy. Yeah, look, I just wanted to reiterate. So I did put a comment in the chat just in regards to electronic prescribing. So very often we are actually the digital health team at the PHN is only alerted to practices that are not issuing e-scripts when it comes from the pharmacy. So if the pharmacists, if you are in contact with the general practices and you are aware that the practices are not issuing e-scripts, then it would be really helpful for us so that we could provide that one-on-one education with those practices to do so. And certainly I know that we have collected some information around which of our residential aged care facilities have got electronic med charts. So I think that would be quite helpful for the pharmacists in the different locations if we're able to disseminate that information if it's not already known.
Thanks for that, Claire. And Robert, I see you've got your hand up as well.
Yeah, thanks, Ivy. Look, I was just thinking, given the number of people who've come in a bit late, if you could do a key points reiteration at this point, it might be helpful for some of the pharmacists. What do you think?
Yeah, sure, no problems. Key points are we're going to get a surge of COVID cases in the next period of time, and we're talking probably over the next 6 months, where we see that transition to living with COVID, i.e. no longer aiming for COVID zero. Restrictions have been lifted and will continue to be lifted, and we're going to see rising case numbers. However, for the most part, majority of those cases will do well. And so there's a level of reassurance that we can provide to our patients around that, particularly if they're young, particularly if they're fully vaccinated, and if they don't have medical and social risk factors, and that they don't have symptoms or only have very, very mild symptoms. In terms of the previous model of care, or what has been happening to date, is that the hospital-led teams have been looking after every single COVID patient in Western New South Wales and certainly across all of New South Wales. But we're certainly transitioning to that new phase of living with COVID, where GP teams will be involved in the care of low to medium risk patients, and the hospital teams will retain the care of higher risk patients. And so you'll be seeing those script requests coming through from general practice as well as from hospital-led teams in relation to usual medications, but also symptom control for COVID positive patients. Lisa's background in terms of her providing care, her and her team providing care for COVID positive patients, very important part of that, of course, is how to do that safely from a risk management perspective for your teams, but also how to do that safely from the patient's perspective as well, so that they get the care that they need. Lisa, did you want to do a few quick dot point summaries of your part of the presentation?
Sorry, I was on mute, sorry. The main thing is have a think about how you'd incorporate everything which Ivy has outlined into your practice around, make sure you've got plenty of stock of those commonly prescribed medications, as well as spaces, and how you deliver the service to meet the needs of these patients, not just around, as we mentioned, symptomatic treatment, but other things that we may come across in terms of NRT, nicotine withdrawal, just basic symptom management around paracetamol and ibuprofen. If you're delivering those for children, the different things that they will need in terms of spaces, syringes, how you'd manage different situations around sort of if you needed to do stage supply of something, say like diazepam, how you'd incorporate that into your workflow, particularly on weekends should they require delivery of medication. And yes, and as Ivy mentioned, just that delivery of medication to meet the needs of delivering Schedule 3, Schedule 4 medications, and should you need to demonstrate device use. So that's probably wraps up from the pharmacy side, Ivy.
And Katie has recorded this webinar as well, so if you've jumped into the meeting a little bit later but you'd like to catch the earlier part of the meeting, it will be there. Shared by email, Katie, or?
Yes, I will share it by email, Ivy. Hopefully by the middle of tomorrow, we'll be able to get that into a small file that can be shared. So yeah, I'll send that around tomorrow.
Thank you. And it's 5 minutes. We could even have an early mark, which is rare. Andrew, are there any final words you'd like to say?
Oh, look, thanks, Ivy. It's been really helpful. I think I would just say to people that we're in this together, and the PHN is here to support pharmacy, general practice, and the patients that we're here to support. I think if you have issues and you want some support, reach out. We're here to help.
Wonderful. Thank you all so much for joining us tonight. Thank you to our wonderful presenters and panelists for all your insights, but also thank you to our participants who have raised a few really good points for us to consider moving forward. If everyone could just take a couple of minutes to do the survey for us, particularly around any further needs, further information, further updates you'd like, we're always really keen to work with you there. But also if you know, incorporating pulse oximeter delivery into your medication delivery might be possible for you. If required, we'd really love to hear from you. But yes, let's all have an early mark. It's Monday. So that's wonderful. Thank you everyone so much for joining us, and enjoy your evenings.
Thank you.
Thanks very
Good
much.
night.
Bye, everybody.